So today I will be discussing management of hypertension both in the inpatient and outpatient setting on my YouTube channel, Rounds in the Fast Lane, which I have created to discuss high yield topics in practical medicine to help interns and residents with their day-to-day practice and also medical students who are preparing for the USMLE exams. The format of my lectures is going to be pretty much the same, where I'll be pulling up the notes that I have created. And if you're listening to this lecture as a podcast, you can just go in the link in the description box below and print out these notes. You don't have to make notes when you're listening to this lecture. So I'll start with the discussion. The first part, that is definition of hypertension, normal blood pressure less than 120 and systolic and less than 80 diastolic. Elevated blood pressure is 120 to 129 systolic and less than 80 diastolic. Stage 1 hypertension is 130 to 139 and 80 to 89 diastolic. And stage 2 hypertension is more than 140 systolic and more than equal to 90 diastolic. Now, the reason this classification is important is especially because if the patient is diagnosed with stage 2 hypertension, you would prefer starting them on two medication, that is the combination therapy, rather than just one initial medication. Again, remember that the diagnosis of hypertension is a more reliable modality of diagnosis is ambulatory blood pressure monitoring or home blood pressure monitoring. You would prefer the patient to have a home BP cuff, take their blood pressure at home and bring the readings to the clinic. And based on that, you can manage the blood pressure, because in the clinic, the incidence of white coat hypertension and masked hypertension is pretty common. So that is something to take into account. Then resistant hypertension is the patient being hypertensive when they are taking three or more antihypertensive medication, including one diuretic. Now, before we discuss how will we manage the blood pressure in the outpatient setting, let's discuss what would be your goal. What would be your goal blood pressure for the patient and how low you want them to come down to. So that is going to change based on the patients having comorbidities or not. If somebody doesn't have any comorbidities and is just newly diagnosed with hypertension in the clinic, you would prefer to bring their blood pressure lower than 130 over 80, and you can keep them between 125 to 130. However, if someone does have comorbidities, like for example, diabetic nephropathy, diabetes, cardiovascular diseases like myocardial infarction, heart failure, stroke, TIA, for them, you would keep them on the lower side, preferably a little bit lower than 120 or at least between 120 to 125. If you consider the patients who are elderly, more than 75 years of age, are very frail, at a high risk of fall, at a high risk of having orthostatic hypotension, becoming syncopal, having tachycardia, in these patients, you can keep them a little bit on the higher side, like for example, in the 140s. You will not drop them down to very low levels unless they have any significant comorbidity that warrants lower blood pressure or stricter control. When it comes to inpatient settings, your goal will depend on multiple factors, as I said, the patient having comorbidities or not. Now, there was an interesting article that was published in JAMA, a cohort study, which showed that inpatient management of hypertension in the patients who were admitted with non-cardiovascular diagnosis, again, remember this, non-cardiovascular diagnosis, and also the patient who have stroke and TIA, these patients were excluded. So the patients who were admitted with no cardiovascular diagnosis, no stroke, no TIA, treatment of hypertension with oral or IV medications was associated with higher rates of AKI and myocardial injury in these patients, and it did not show any benefit. However, if the patient is admitted due to cardiovascular diagnosis or has a stroke or a TIA from the high blood pressure, they do warrant strict control. So, as I said, your goal is going to depend on the patient, and it's not going to be same for every single patient. Now, coming to the choice of medication, now let's start with the people who do not have any comorbidities. What will be your first line choice of medication? So the four go-to drugs are A, B, C, D, that is ACE and ARBs, beta blockers, calcium channel blockers, and diuretics, mainly thiazide diuretics. Now, uh, previously we were having this notion that the patients African American patients are better respond to diuretics, thiazide diuretics like hydrochlorothiazide and calcium channel blockers. But if you see the recent data that is coming up, and in January 2022, the Journal of American Board of Family Medicine came up with an article which showed that now we can use any medication as the first line management, including in the patients who are African Americans, and they not necessarily, and you do not necessarily need to use diuretics and calcium channel blockers, which the previous trials showed worked better in that population. So now you can choose any of these, and preferably the first line medication is ACE and ARBs in most of the patients, unless they have any contraindications. Now, one important thing that you have to learn as an intern or resident is dosing of the blood pressure medications. Now, for example, if you're choosing ACE and ARBs, there are many ACE and ARBs, lisinopril, losartan, valsartan, many of them. And some of these medications have a dose that's meant for heart failure mortality benefit when the patient's blood pressure is on the softer side. So an example of lisinopril, which starts from a dose of 2.5, 5, 10, 20, 40 milligrams, if you use a dose of 2.5 in the patient who has long-standing hypertension, is obese, the weight is more than 90 or 100 kgs, and you're using a dose of 2.5, it's unlikely to work in them. So before you decide what dose you're going to use, you have to take into account for how long the patient is having the blood pressure, uh, and also whether or not that dose is for heart failure or high blood pressure. So keep that in mind, and then you can up titrate as needed for any medication. For calcium channel blockers, usually the first line medication is amlodipine, which starts with a dose of 5 milligram, and you can up titrate to 10 milligram. But if you want to further up titrate calcium channel blocker, you can consider nifedipine or nifedipine sustained release, which is available in the doses of 30, 60, and 90 milligram. So if you see a patient that's not being controlled on amlodipine, you can switch it to nifedipine and then up titrate it. Similarly, for thiazide diuretics, hydrochlorothiazide, you can start with the minimum dose of 12.5 and then up titrate. And if hydrochlorothiazide is not working, then you can go to chlorthalidone, which is a much stronger thiazide diuretic. Then coming to beta blockers were previously used very commonly as the first line medication, but nowadays they are not considered a great medication to control someone's blood pressure unless they have a comorbidity that warrants the use of beta blockers. Even in beta blockers, I would say the non-selective beta blockers are preferably a better medication to control blood pressure, like carvedilol and labetalol. So if a patient has, let's say for an example, atrial fibrillation, and you're considering something just for rate control and the pressure is fairly controlled, you can consider atenolol or metoprolol. Most of the times we use metoprolol. But if this same patient has elevated blood pressure, then carvedilol would be a better choice to control the rate and also the blood pressure. Then the side effects of every medication I will be discussing in the end. And as I said, the first line medication is going to depend not just on these four, which, as I said, was for the patients with no comorbidities. If somebody has comorbidities, then the first line medication is going to change. Like, for example, if someone has diabetes, diabetic nephropathy, proteinuria, CKD, for them, ACE and ARBs are the first line medication. If somebody has heart failure to reduce ejection fraction, we know ACE, ARBs, beta blockers, and aldosterone antagonists like spironolactone have shown mortality benefit. So for them, the first line medication will be these ones. You will start them, up titrate them to the maximum dose, and then add something else like a calcium channel blocker if needed. But otherwise, the first line medication is going to depend on the comorbidities. And then for Raynaud's, calcium channel blocker is the preferable first line medication. If somebody is having atrial fibrillation, as I said, beta blockers and non-dihydropyridine calcium channel blockers like verapamil and diltiazem will be the first line medication. If somebody is having migraine, we know we use propranolol and verapamil for migraine prophylaxis. So if the same patient comes in with hypertension, this is something that you will consider using as the first line medication. If somebody has benign prostatic hyperplasia, then an alpha blocker like doxazosin, which also helps reduce the blood pressure, can be considered. So the point I'm trying to make is, based on the patient's comorbidities, the first line medication is going to change. And then I'll go over the contraindications with the side effects in the end. Now, let's come to the next part, that is inpatient management of hypertension. And first, we're going to start with management of hypertensive emergency. So, previously, we used to have this term hypertensive crisis, which was divided into two parts: hypertensive urgency and emergency. Hypertensive emergency is when we see the signs of end organ damage. But now, for hypertensive urgency, we prefer using the term severe asymptomatic hypertension. The blood pressure in this case is going to be systolic more than 180 and diastolic more than 120. So for signs of end organ damage, when we call it hypertensive emergency, you're going to look at the brain, eyes, heart, and the kidneys. If the patient is having a stroke that's precipitated from the high blood pressure, ischemic or hemorrhagic, severe headache, loss of vision, blurry vision. In case of heart, if there is a troponin leak, EKG changes, patient having congestive heart failure and going into acute exacerbation from the high blood pressure, having flash pulmonary edema, and acute coronary syndrome, aortic dissection. In all these cases, we will consider it as hypertensive emergency. If the patient is having renal dysfunction, elevation in the creatinine or AKI from this elevated blood pressure, then we'll say it's hypertensive emergency. Now, the reason we differentiate between these two categories of urgency and emergency is because the goal blood pressure to which you will drop down is going to change. If it's hypertensive urgency or severe asymptomatic hypertension, you will consider lowering the blood pressure very slowly over many hours or days. This is because if you drop it too quickly, you're going to precipitate a stroke. When the patient has long-standing high blood pressure, uh, there is vasoconstriction in the brain, and if you suddenly drop the pressure in such a case, you can precipitate an ischemic stroke. Remember, having mild headache is not a part of hypertensive emergency. A patient with urgency can also have mild headaches, but unless you see these true signs of end organ damage, we will consider it urgency and not emergency. When it comes to hypertensive emergency, you have to quickly drop the blood pressure at least 10 to 20% in the first hour and at least total of 25% within the first 24 hours. The only exceptions here is a patient having ischemic stroke, because in ischemic stroke, you're going to go with permissive hypertension uh, to help with the perfusion in the brain up to at least 24 to 48 hours, unless if the patient is a candidate for TPA. If you're about to give TPA, you have to drop the pressure to a little lower than 185 over 110. If the patient is not a candidate for TPA, then you can keep them at a higher blood pressure unless the pressure is more than 220 over 120. If it's more than 220 over 120, then you're going to bring it down and keep them there. Then for aortic dissection, definitely you're going to rapidly reduce the blood pressure to systolic hundreds or 120s within the first 20 to 30 minutes and keep the heart rate below 60. When it comes to hemorrhagic stroke, I see hemorrhage, it's variable. The systolic blood pressure, if it is between 150 to 220, you're going to rapidly reduce it to 140 within first 1 hour. If the systolic blood pressure is more than 220, you're going to rapidly reduce it until it is lower than 220. And then after that, you're going to gradually drop it down. So for hemorrhage, it's actually a multidisciplinary approach. You're going to have neurosurgery, neurologist on board, and then have a discussion at where you would want to keep these patients. But it's very important for you to know the guidelines for ischemic stroke and aortic dissection. Now, since in hypertensive emergency, it's the goals are this strict. You would want to use a medication that you can easily control. So that's why we use drips. Drips are the forms of medication that you start it, its action is going to start, and you stop it, its action is going to stop. So we prefer a medication that is fast, has faster onset of action, and is short acting. So it's easy to control the goal. So what medications can we use? There are multiple medications available like nicardipine and clofazimine, which are calcium channel blockers, nitroprusside and nitroglycerin, which work via cyclic GMP pathway, labetalol and esmolol, which are beta blockers, and phenol-dopam, which is a dopamine agonist. Now, each of these medication has its own benefits and side effects, and the first line medication, as I said previously, is going to depend on the patient. And also a lot of times there are institutions, every institution has its own every attending has its own preferred first line medication. So nicardipine is mainly used. It's a preferred drug of choice in stroke because it prevents the cerebral vasospasm. It's a relatively longer acting and has a long onset of action. So that is something to keep in mind before you start a nicardipine trip. You can use this to your advantage because if you want to bridge the patient to oral medication and you want an IV medication that is going to relatively last in the system longer as compared to other meds, then this is something that you would consider. Then the other one is clevidipine. It is an ultra short acting, very fast onset of action, and it wears off quickly if you stop the trip. So this is something that can be very easily controlled. The only problem is it's contraindicated in severe aortic stenosis, and you cannot give it to a patient who is allergic to eggs and soy. Then coming to nitroprusside, for all the medical students, this is one of the first line drugs mentioned in the books. And the good thing about this again is it's short acting and has fast onset of action, and it is a good medication for heart failure, for blood pressure control. But the problem is it's not that commonly used as it used to be because of the side effect of cyanide toxicity. If somebody is on nitroprusside for 48 to 72 hours, usually longer periods of time, then there is a high chance of cyanide toxicity. So if you think that the patient is going to need a blood pressure medication for a longer duration of time, especially for 48 hours or more, then I would recommend avoiding nitroprusside. Then coming to nitroglycerin, this is the nitroglycerin drip. It is also one of the really good medications, especially if somebody is in acute exacerbation of heart failure, because it is a primarily venodilator and helps you reduce the preload. Also, it helps with chest pain. So you must be knowing if somebody is having an acute coronary event, we give sublingual nitroglycerin, and when that doesn't work, we start the patient on nitroglycerin drip. So it helps with the chest pain as well. The problem with this is it causes headaches, so it can precipitate headaches, and at times the patient will not be able to tolerate it. Then coming to labetalol and esmolol, they are primarily beta blockers and mainly used in aortic dissection. The problem with them is they can worsen bronchospasm, and if somebody has history of COPD or acute exacerbation of COPD, it can worsen it. And of course, you cannot use it in acute exacerbation of heart failure because of the negative inotropic effects. Then coming to the last medication, phenoldiprem, it is not usually a first-line go-to medication unless the patient is in AKI from the hypertensive emergency, and it helps with the renal perfusion. Uncommonly used as the first-line medication. Most commonly, you're going to see nicardipine drip, clevidipine drip, and nitroglycerin drip as the first-line medications in a lot of hospitals. Now, coming to inpatient management of hypertension. Now, as I said previously, in hypertensive urgency, you're going to slowly drop the blood pressure. And if the patient is in the hospital and you're paged about the patient having high blood pressure, but you do not see any signs of emergency, or if the patient is a diagnosed case of hypertension coming in the hospital, inpatient stay, and the nurse pages you that the patient is having super high blood pressure, elevation in the blood pressure. So you will see most of the times PRN or as needed orders are placed for hydrolazine and labetalol, and you're going to set a parameter, like for example, systolic blood pressure more than 160 or 170, and the nurse is going to be able to administer hydrolazine or labetalol IV Q6 hours or Q4 hours as you've set it. But this approach is usually it's like putting a band-aid on the problem. So whenever you're paged for the patient having elevated blood pressure, the first thing you're going to do is look at the vitals as a whole. You will look at the patient's heart rate as well. If the patient is having super high blood pressure with tachycardia, with the heart rate in the hundreds, 120s, it's very likely that the elevation is secondary to something else, like for example, pain, anxiety, the patient going into withdrawal from alcohol or opioid. And if you do not address these underlying causes, just giving IV hydrolazine or labetalol pushes will not help with the management of the blood pressure. So if the patient is in pain, is post-op, or in pain due to any other condition, you would address that first, give pain medication. If the patient is anxious or in withdrawal, you're going to treat that. If the patient is in delirium, reorientation will help the patient and treatment of the delirium. If the patient is volume overloaded, congested, you would diurese them first. When it comes to inpatient management of hypertension, IV enalapril is one of the really good medications. If the patient is not dehydrated, hypovolemic, or is in AKI or renal dysfunction, then IV enalapril is one of the great medications to consider because, uh, unlike hydralazine, which causes reflex tachycardia, is short acting and quickly drops the blood pressure, enalapril usually will have a slower onset of action and is going to stay in the system for a longer period of time. So it's actually a good medication if you're considering inpatient management and you want to give something IV, unless there are any contraindications. The problem with IV hydralazine, as I said, is that it quickly drops the blood pressure and causes reflex tachycardia. So if the patient has a tendency to be tachycardic, is has a history of AFib, has a tendency of going into rapid ventricular rhythm, hydralazine is something that I would recommend to avoid. Then IV labetalol, again, like IV hydralazine, is shorter acting, and you have to give it round the clock. So in any case, you would, if the patient is a diagnosed case of hypertension already and is taking medications at home, you would prefer starting their home medications in the hospital, bridge them to oral medication as soon as you can, and try to get them off the as needed IV hydralazine and labetalol pushes as fast as you can. So that is something to consider when you're managing the blood pressure in the hospital. Now, coming to the other medications, as I said, resistant hypertension. Now, a lot of times you're going to see, you're going to admit patients with ESRD on hemodialysis, and you're going to see that they're on multiple blood pressure medications. So the patients in whom it's extremely difficult, who are already on ASARBs, calcium channel blockers, or thiazide diuretics, and you see that they're still not controlled. So these are something that are miscellaneous drugs, which are add-ons to the usual modality of management. So diuretics like aldosterone antagonists, loop diuretics can be added on. Hydralazine, which is usually 3 times a day dosing, available in the oral form as well, can be considered. Again, keeping in mind that it can cause reflex tachycardia and quick drop in the blood pressures. Then clonidine is also one of the very strong medications, short acting, available in the oral form and also has a patch. The problem with clonidine is if that patient misses their dose, it can cause rebound hypertension. So that is something to keep in mind. Then minoxidil and alpha blockers like doxazosin and nitrates. Nitrates can be used if the patient has angina and you also want to control their blood pressure. So that is something that you can consider based on the comorbidities. Again, these medications are not the first line medications, and you would only consider them as an add on in the cases of severe resistant hypertension, especially in the patients who are ESRD, on hemodialysis, or if the patient has heart failure and repeatedly going into flash pulmonary edema due to uncontrolled blood pressure, are already on goal directed medical therapy, and then you will consider something to add on. So coming to the last part of the lecture, I would just quickly go over the side effects and something that you will keep an eye for. If the patient is developing those side effects, you can either stop these medications, or if they have a high tendency or having any contraindications, you would consider not starting them. So for ACE and ARB, something that you will commonly see is hyperkalemia, orthostatic hypotension, especially in the elderly. Patient can have AKI if they are severely dehydrated and also on ACE and ARBs. Then cough and angioedema with ACE inhibitors. And the patient is having those, you can consider switching them to an ARB instead of ACE inhibitor. Then with calcium channel blockers, peripheral edema is a common side effect, and uncommonly you will also see constipation and gingival hyperplasia. It's gingival hyperplasia is usually after using it for a very long time, and there are only some case reports that describe this side effect. So the main thing that you keep in mind is the peripheral edema. With thiazide diuretics, you can remember the mnemonic hypergluc, that is hyperglycemia, hyperlipidemia, elevation in the uric acid levels, and elevation in the calcium levels. So as it causes elevation in the uric acid levels, you would avoid them in cases of gout. Then again, they can also cause AKI and renal dysfunction if the patient is overdiuresed. Then hydrochlorothiazide, thiazide diuretics like HCTZ is also associated with hyponatremia. So that is something that you will keep in mind when you follow up the patient over a period of time and look at their labs. Then beta blockers are associated with increase in bronchospasm. And if somebody is a patient who has chronic COPD going into multiple exacerbation episodes, then you would prefer to take them off a beta blocker and switch it to something else. And then bradycardia, of course, for the beta blocker. Then coming to certain contraindications, as I said initially, cocaine use, you would avoid beta blocker. Uh, Sometimes you will see that some experts and consultants can consider using non-selective beta blockers for the patients who are using cocaine, like carvedilol, because they have both alpha and beta blocking properties. But keep in mind that all the beta blockers have predominantly beta blocking properties. So if you can avoid it, you should, and consider something else. But let's say if the patient is having atrial fibrillation from cocaine use, precipitation, and if the patient is having heart failure with reduced ejection fraction, and if the beta blocker is needed, then a non-selective beta blocker can be considered, but definitely not a cardioselective beta blocker in the patients who use cocaine. Then in patients who are hyperkalemic, of course, you will be avoiding ACE, ARBs, and aldosterone antagonist. For gout, as I said, thiazide diuretics, and if the patient has heart block, symptomatic heart block, then non-dihydropyridine calcium channel blockers like verapamil and diltiazem, and beta blockers. So that is pretty much it with the management, both inpatient and outpatient, for hypertension. If you have any comments, you can mention it in the comment section below. Again, in the end, I would like to say that this discussion is mainly based on my understanding and my reading of medicine. I would highly recommend that you see the video and go and read up on all the topics from different sources, discuss it with your attendings and professors. And the best way to learn medicine is to actually practice it and not just reading. So use this knowledge when you're practicing medicine, discuss it with your colleagues, and get better at it. And that's all for this lecture. Thank you so much.